Good morning, good afternoon, good evening from wherever you're joining us. It is my pleasure to welcome you to the first of many webinars that we'll be hosting through the Canadian Ophthalmological Society. The theme is a path to a new vision. And the goal of it is to have stimulating discussions and to have some actionable items at the end in the form of toolkits through the Practice Resource Center from the COS. My name is Guillermo Rocha, and I'm happy to welcome my co-moderators who are part of the COS CPD Council, the Council on Professional Development. We have our distinguished guest speaker, Dr. James Shodash from Boston. And I would like to thank, because this was put up in the past few days as an initiative to fill a void, I would like to thank specifically Cheryl Ripley as well as Colleen Drake, who are really the brains behind the CPD Council for the COS. I'd like to introduce Dr. Yvonne Bice, our current COS president, for some words of welcome.
Thank you. COVID-19 has created a new environment, and we as ophthalmologists face significant challenges in our personal lives and in providing care for our patients today and as we look forward. The COS is responding to these challenges with the development of position statements related to the practice of ophthalmology during COVID, which can be found on our PRC. We've changed the format of the annual meeting to a virtual platform. Recently, we provided a limited number of free slit lamp breast shields to members, and I'm pleased to say in under 24 hours, we only have 10 left. And finally, today's program. This is made possible through an unrestricted educational grant from Bayer. This is going to be a webinar series entitled A Path to New Vision on COVID-19 topics. I'd like to also thank all of those involved with this project, and specifically Colin Mann, who really inspired the idea. Finally, I'd like to wish all of our members health and resilience during this difficult time. Things will get better. Thank you.
Thank you very much, Yvonne. And with this, I would like to tell you the structure of the webinar. And basically, what we're trying to do is something that offers hope. And for that, I think many of us who are in isolation start thinking about our childhood things and stories. And growing up in Mexico, in Latin America, Mafalda was a cartoon character developed by a political cartoonist called Kino. She was very intuitive and very in tune and very preoccupied with the things that were happening in the world. So one day she was reading all these headlines and she basically said, "Stop the world, I want to get off." So rather than doing that, because we really can't do that, we at COS wanted to provide a path to a new vision by having the different stages and how to prepare for that new normal whenever it may come. So we've organized a series of seminars or webinars that will hopefully tackle some of these issues. And the first one is on understanding the SARS-CoV-2 virus and also the role of protective equipment. But we also hope to have others on teleophthalmology, medical legal issues, as well as wellness to take us to that other side after this is all done. I'd like to introduce now, and it is a true pleasure to introduce Dr. James Shodash, who's a professor at the Massachusetts Eye and Ear Infirmary in Boston, Harvard Medical School. He deals with cornea, he deals with ophthalmology, he has a master's in public health, so he deals with epidemiology, and he deals with the PhD program in virology at Harvard University. I simply cannot think of any better suited individual to really help us through this initial launch of our webinars. So with that, Jim, we'll start off to frame sort of the position of the Canadian ophthalmologists and those who are joining us. I'll ask Colleen to sort of give us a framework with a poll that we'll run right now, and it will start with the status of the practice. You're able to run that, Colleen? There we go. So if I can ask you to answer fairly quickly. Are you open only for staff and administrative work? Completely open, business as usual? Only open for urgent or emergency care? Urgent for urgent or emergency cases, but implementing telehealth? Or completely closed? This is over. And can we see the results? There we go. So the majority are open for urgent and emergency cases, but implementing telehealth, telephone video via EMR. So we're adapting. The next two questions, Colleen, if you can put them, relate to personal protective equipment, PPEs. And so we want to get an idea between the hospital setting and the office setting. What are the differences in what you're doing there? We'll pop out that question. There. So if you're seeing patients in a hospital, so no protection, breath shields on examining equipment, hand washing or gloves, hand washing, gloves, mask, eye protection, breath shields, or the full shebang. And you have the second question down below with the exact same options, but this is in the office setting. And we'll look at the results. So hand washings or gloves, masks, eye protection, breath shields on examining equipment, and the same for hospital as well as, it's the same for both hospital and the office. So that gives you a framework, Jim. So we'll carry on with your presentation now. Thank you for joining us. So I was wondering, to start, Jim, if you could give us a background of how you got involved with this. You had a great role in the American Academy guidelines.
So it was all my fault. You have to excuse me. It's not a dry COVID cough. It's the piece of popcorn that I tried to aspirate 15 minutes ago. That's giving me a hoarse throat. So I chair a Academy Committee on Research and Regulatory Affairs and Scientific Affairs, and we had our Secretariat meeting, which is held in January of every year. And COVID was just coming up, and I had read about a SARS pulmonologist, kind of a hero in China, who got COVID despite wearing an N95 mask on his travels to inspect hospitals. And his first symptom was conjunctivitis. 4 hours later, he had a fever and then an upper respiratory symptoms. And it occurred to me on the day of this meeting that ophthalmologists in the United States might be seeing patients with COVID and not realize that the viral conjunctivitis they were seeing was actually something much worse. And I mentioned it to Dr. Park, CEO of the American Academy, and he looked at me and he said, "Oh, this sounds urgent." So he asked me to write something, and the next day, to my surprise, an email with most of what I had written went out to 34,000 ophthalmologists, which was scary because, what if it was wrong? It turned out the information in that email was correct. That was the end of January. In late February, he contacted me, Dr. Park contacted me to ask me if I would help with this page, which was at that point getting thousands of hits a day, and it ramped up to about 50,000 views a day. And it's now, I think, at over 1.25 million views, which is crazy. So on a daily basis, I go in and edit a Google document based on what I've learned that day. The Academy has been fantastic, and I'm helped by Gary Holland at UCLA and Stephen Ye at Emory, who were recruited once the Academy realized I was in over my head in terms of the volume of work. And we're still going, and I expect we'll be at this probably another month or so. I hope that the dust settles sufficiently so that at least we know what's ahead of us. But it's still, information on this epidemic and on the virus is very much still a moving target. We're learning so much more every single day, and some of what we're learning tells us that what we thought we knew in some cases was incorrect. So I wanted to tell you a couple of things about the virus, just to give you just a brief background so we can get that out of the way. And I do want to thank Dr. Rocha, Dr. Baez, and Dr. Mann for inviting me to do this. It's a huge honor to be speaking with my friends and colleagues in Canada. So, were you going to bring up the other slide set?
Correct. And there we go.
Awesome. So this is, thank you. So this is the most likely reservoir for this virus. It's the horseshoe bat. Of interest is that coronaviruses evolved from a common virus that also infects the anteater, which is something that I learned recently, which was kind of shocking. Next slide. This is it's a colored electron micrograph. So this isn't actually the color of the virus. The color is added artificially, but it's called a coronavirus because of its appearance on electron microscopy. It's an envelope virus, but from the edge of the envelope, these spikes, which is a protein capsimer, these spikes project, and it's this spike protein, it's literally called that binds to the receptor on the cell. Next slide, please. This is a structure of the virus reconstructed in silico, and you can see these red spike proteins. Next slide. And again, this is a positive sense RNA virus, single-stranded RNA genome. And positive sense means that it's ready to be translated or directly into protein. It doesn't have to go through additional processing. And it's similar in its structure to dengue virus, West Nile, and even the common rhinovirus, which is the most common cause of the common cold. This virus has 80% sequence identity with the virus that caused the SARS epidemic. And it's the spike protein binds to angiotensin converting enzyme 2, or ACE2, on the cell surface. And this is a very widely expressed receptor on epithelial cells. And you know that this virus causes lung disease and gastrointestinal disease, and the receptor is present there. But the virus can also be neuroinvasive, hence the symptoms of loss of smell and taste, and patients who've developed encephalitis and encephalopathy. It's thought that it can possibly infect the heart because patients have developed myocardiopathy that doesn't seem to relate to the other medical conditions they have. It's caused strokes. It seems to cause a coagulopathy. It causes thrombosis as opposed to sort of exhaustion, such as you would see in bleeding disorder. This causes clots. There was a recent Broadway actor who had to have his leg amputated because of a thrombotic event while he was on a respirator for COVID. So it's causing a lot of disease that goes well beyond lower respiratory tract infection, which appeared initially to be the sine qua non of the infection. Next slide. This is an electron micrograph, and again, it's been colored in by the authors, but this is in lung tissue, human lung tissue, and the virions are large, and it makes a lot of them. Next slide. This is a case that was just published in the British Journal of Ophthalmology, and I wanted to just show it to you because it is, everybody keeps asking about SARS-CoV-2 in the eye. This was a confirmed case of conjunctivitis. This was a hospitalized patient. Next slide. And these are the symptoms. So the arrow on the left points to when the red eyes occurred. So it was on day 13 of hospitalization, and the redness went away a few days later. The patient was being given ribavirin eye drops, which, based on mechanism of action, should have no benefit, but the authors thought that it did. Regardless, the patient, next slide, was culture positive for, or not culture positive, RT-PCR positive for the virus. The quantity of virus appeared to be well below what was found in nasopharyngeal swabs or in sputum, but above what was in saliva. So they did find virus. Next slide. And the conjunctivitis was mild. It was a follicular conjunctivitis with some tearing, and it resolved in a few days. And this is what's been reported. So, the cases that you see, like the epidemic keratoconjunctivitis conjunctivitis cases with membranes and corneal involvement, that's not this. There have been no reports of severe ocular infection to date due to this. Now, the authors, knowing that coronaviruses experimentally can infect retina, next slide, actually took the patient and did retinal studies, which I thought was remarkable that they would take a COVID positive patient and do this, but they did. And what they found was essentially a normal retinal exam, both morphologically and by OCT. And I don't think there are any more slides, but you can check and see if there's one more. Nope, that's it. So, Graham, maybe you want to go back to your slide set.
Great.
So as far as ophthalmic manifestations, the others that I've been told about as anecdotes, an ophthalmologist actually informed us that he had COVID-19 with no respiratory symptoms, and his symptom was severe eye pain. The reports suggest that hospitalized patients, some of them had chemosis, but that may be because they were third spacing. Red eyes have been reported anecdotally in nursing homes with elderly patients where COVID was prevalent, but no one has really been able to do any more detailed investigation. So it probably can cause a conjunctivitis, maybe in 1% of cases. It appears to be mild, but it's just something to be aware of when you see a patient with conjunctivitis, and they may be otherwise healthy.
Okay. Thank you. Thank you for that, Jim. So as we move on through some of the interactive questions, what data should we be looking at? We get flooded with information. Should we be looking at the cumulative data, the daily data, and realizing that there's realistic and there's real current testing and contact tracing. So what should we be looking at when we look at these graphs? And these are taken from just a couple of days ago in Canada by different provinces.
So personally, what I find useful, missing from many of these graphs and data points is the denominator. The denominator is the testing number. Unless you know how many people are being tested and what proportion of the community and what the testing criteria are, it's difficult to interpret positive tests. Massachusetts had double the number of cases yesterday, but they more than doubled the number of tests they had done over any previous day. Mm-hmm. So, that's an important criteria. Personally, I like to look at our own sister hospital, Mass General Hospital's intubation data, because to me, that's the sign of severe disease. And at least in Boston over the last few days, the number of patients who are intubated seems to be slowly going down. Now, some of those have died, but the number up until a few days ago was rising pretty rapidly. So that tells me that maybe things are starting to level off in Boston. We don't really have universal testing, obviously, and any testing results you see, you need to understand how many tests were done and what were the circumstances. For example, when the testing criteria are loosened, probably there'll be less positive tests per test done, as opposed to taking a patient who obviously is sick, has all the very specific signs of COVID-19, and then gets a test. That's where we would expect the test to be more likely positive. Exactly. So, the numbers have to be interpreted with care, and the denominators always need to be kept in mind.
Okay. So politics and economics aside, forget about that. What makes the most sense to tackle this pandemic? People have said do nothing, mitigate, hammer the dance, and this is taken from an article by Thomas Puello.
I highly recommend this article. It makes a very cogent argument for what the author calls the hammer and the dance. So the problem with doing nothing or simple mitigation and doing nothing might work in places that, well, let me take a step back. One thing we don't know about the virus is whether the virus is going to be less transmittable or transmitted less in hot climates. We don't really know that. There are epidemiologists who believe this is a virus that is highly transmitted in a certain temperature range and then otherwise not. The outbreaks in Wuhan, in Italy, in Spain, in Washington, Seattle, in Boston, New York, were all in that temperature range. There's another group that believes temperature has nothing to do with it. Now, envelope viruses don't do well in heat and ultraviolet light, but that aside, we don't have the answer, and the experts at NIH don't have the answer. They're not settling on one side or the other at this point. If it's a seasonal virus, mitigation and doing nothing in an area where there's very low prevalence right now might be okay, maybe. But the reality in those places that have had significant outbreaks or verging on that is that the cases can exceed the medical system's ability to handle them. So, I'm volunteering in our own emergency room, but that's for eye cases. If we get much worse in Boston, I'll be seeing patients in Mass General's general emergency room. because we won't have enough caregivers. We'll have patients in the hallway the way they do in New York. Clearly, New York is where no one else should want to be.
Mm.
The numbers of cases and the severity of disease has greatly exceeded their capacity to take care of the patients. They don't have the personal protective equipment or the human beings to do it, or the beds or the ventilators, you name it, they're out. So doing nothing puts a large part of the US and potentially Canada at risk for a true crisis. And not only COVID-19 patients will die, but patients who need routine things, patients with heart disease, patients with uncontrolled diabetes, patients with strokes. And I'm sure that some of them are dying inadvertently in the US right now because they're afraid to go to the hospital. We've been seeing, from the ophthalmological point of view, patients who are hesitant to come in. We had a patient with zoster that was probably quite manageable that waited 3 weeks to come in. It's a longer story, not worth taking the time of this audience, but they developed a complication that was completely avoidable had we seen them in due time. And there's going to be a lot of that in Boston, and I'm sure it's happening in New York. So I don't think that anywhere where the virus has shown up that doing nothing is an acceptable strategy. And the idea of social isolation and taking extreme measures is to be able to limit the number of cases until you can ramp up what you need: beds, ventilators, personal protective equipment, training, knowledge about the virus, maybe a therapy that might be at least moderately effective. Give us more time till we can get to possibly a vaccine. That's the whole idea. That's the hammer, is the draconian measures and the distancing. The dance is to try to continue the distancing and protective measures until you can get all these other things in place so our healthcare system can manage the patients. Excellent.
Now, we talk a lot about personal protective equipment, there's different ways here to look at it. There's a lot of area where there's really asymptomatic, but we're very, very infective compared to other viruses. So what should we be doing in terms of us as ophthalmologists? What would be the rationale for the personal protective equipment, and what do you think would be the ideal?
So when this started and we thought that that prevalence was very low in most places, we were doing it by basis on symptoms or exposure to a known case, or by travel. In the US, there are so many cases and the prevalence seems to have gotten to the point that even in the low prevalent areas, I personally think that ophthalmologists should be social distancing in their waiting rooms, seeing urgent care only, and using personal protective equipment. Now, any discussion of PPE has to be founded in availability and supply. I cannot put on an N95 mask knowing that the critical care doctor next door, the intensivist, the anesthesiologist, the otolaryngologist who's doing aerosol generating procedures doesn't have one. I can't ethically do that. So I think any discussion of PPE should be in the context of what's available, with modeling of what might be needed and of the supply chain. I'd like to drive to work in a Hummer and stay inside to see my patients if I could, if that was going to protect me, but it's not socially responsible to use, for example, an N95 for routine examinations. Mm-hmm. So we recommend that you consider that any patient you see could have COVID-19. And the reason I say that is emerging evidence is that, first of all, you're infectious for 3 or 4 days before you show symptoms. So that's the pre-symptomatic stage. Current evidence shows that many patients, maybe half of the patients, maybe more, maybe less, are never symptomatic with any classic symptoms. So that means that the spread from a asymptomatic or pre-symptomatic patient is actually more likely than spread from someone with symptoms. Especially as we put a mask on everybody with a cough, you're more likely to get the infection from someone who's not showing symptoms, who's not using distancing or wearing a mask. So personally, in my lane, I keep one exam lane for my patients. I disinfect it myself because I know what I touch and I know what the patient touches. And I do that between every exam. The patient is wearing a mask. A surgical mask works. There's a Nature Medicine paper where they assayed patients with influenza, coronaviruses, and they looked at aerosols, and surgical masks work fantastically at preventing spread from the infected person into the environment. So your patient should be in a surgical mask. I believe you should be in a surgical mask. I believe you should be using eye protection. We strongly advocate breast shields. There are people working on adapting those for indirect ophthalmic exams, and hopefully something of that nature will come out soon.
Okay.
I'm not a fan of gloves because, you know, if you touch the patient with a glove and then touch other places, you contaminate it. I prefer to disinfect my hands every time I touch a patient, I go right to the disinfectant. And between every patient, I disinfect all the surfaces, the computer terminals, the slit lamp controls, everything. Surgical masks work. They work to prevent spread by the person wearing it. A surgical mask doesn't protect you from what's in the air. So everybody should have a surgical mask on.
Okay. You think we can disinfect these and reuse them?
Yeah.
People have talked about putting them in the oven and then,
Yeah.
or using UV light.
Yeah, so UV light can, if not done properly, damage the mask. We have a facility now in Boston that's disinfecting them in a way that doesn't destroy the mask. If you're going to do it at home, my best advice, based on my reading, is steam. To suspend the mask for 10 minutes over steam, like over your home steamer. 10 minutes suspended over steam. You don't want the mask to touch metal that's hot, because the temperature of the metal is higher than the steam, and it can damage the mask. You know, I think we use one mask continually all day long, and we try not to touch that mask. Otherwise, there would never be enough. But I think you have to look at your local supply chain, figure out how many you have, how many you're going to need, and make decisions. If we all had enough to put a fresh mask on for each patient, great, but are we taking masks away from people who need them even more than we do? Okay. So that disinfectant measure was for N95s. Surgical masks, you know, you could also use hot water. If you look below the red, you can see hot water vapor from boiling water for 10 minutes. That's something anybody can do, but you need to suspend the mask over the boiling water. Don't put it in the steamer and drop it onto the steamer bottom.
Okay. Now, what can we expect? We talk about vaccines, they're a long time away. We talk about herd immunity, and we talk about that, the hammer and the dance. And so what is the reality with this? There seems to be a lot of options in terms of vaccines, RNA vaccine, DNA vaccines, but also trying to sort of get our immune system to work. So what is your opinion on this? What can we expect?
So it's very much very murky. First of all, we don't know to what degree prior infection protects against future infection. We don't know. We'd love to believe, all of us, that once you've had it, that you're protected at least for a few seasons. But the data's not out. In addition, there are people who are recovered from COVID, are PCR negative, who then become positive again. We don't know whether they've been reinfected. The genetic studies have not been completed, or whether it's the original virus they had from the beginning. I would suspect the latter, but we don't have the data. In South Korea, they had quite a few patients like this that were discharged and then became PCR positive again. Exactly. So we don't know. That's a key question. We may learn something from the plasma studies, where people are getting plasma from patients who recovered as a way to treat severe COVID-19. If those antibodies rescue them, then that might be some indication. It's not clear to what degree antibodies are the best way to protect, or whether we need T-cell mediated immunity. We don't know that. Herd immunity is a nice idea, but the 5% is not herd immunity. And in achieving herd immunity, such as some have advocated in the US, there will be so many deaths that it becomes an absurd concept to try to get to herd immunity by allowing people to die. As far as vaccines go, all I can tell you is, until one works, nothing works. The history of vaccines is such that many, many, many more are tried and fail than work. Look at the Ebola history. Look at it. Well, influenza is a little bit different virus, but if you look at the history of vaccination, we got lucky with polio. If we're that lucky with coronavirus, we'll be in great shape. But it's going to be a while, and that's why the world's going to look different for the next year or so, at least, until we can find that out. As far as treatment goes, Personally, I don't think that there's any convincing data on any treatment. And the Infectious Disease Society of America recently said that treatment should be used, a drug treatment, including hydroxychloroquine, chloroquine, remdesivir, some other drugs, should be used only in randomized clinical trials and not on an ad hoc basis, because the data was not there to justify. And all of these drugs, including IL-6 antibodies that seem to have some benefit, also have detriment. And the safety profiles that are developed for these drugs do not apply to someone who's so severely ill. You cannot know whether a drug is safe in a COVID-19 patient who's intubated as compared to a person who's walking around and feeling okay. So it's complete open question, and I don't think we have any data yet. The remdesivir that everybody was so hopeful for, there's some data out yesterday suggesting that it failed, but that was a trial in which patients could be enrolled up to 12 days after onset, and some people think that was too late. We all know about antiviral therapy. Usually it needs to be instituted early. So it's an open question. I pray every day for treatment because it would allow us to go back to work and resume our lives with a little bit more confidence than we have now.
And so even if we look at this curve here with the IgG, we don't even know the length of that, correct? We don't know if whoever gets the positive IgG will be immune to the disease.
Patients start to become seropositive 7 to 14 days out from onset of infection, but we don't know how long it lasts. We don't know whether more, a higher titer is better. We just don't know.
Mm-hmm. Okay. Well, I mean, this is a thing. I always have enjoyed this this quote from Nelson Mandela. I learned that courage was not the absence of fear, but the triumph over it. I think you have given us a lot of knowledge at this point that hopefully will allay some of the fear, but there's still a lot of questions that remain unanswered. And so we have a few questions from our group, and let's see.
I can see those.
You can see those.
Yeah.
Perfect. You want to tackle into those?
Yeah. So from a basic science view, why should we not switch away from ACE inhibitors? So the American College of Cardiology is not recommending changing away from or stopping ACE inhibitors. It's a complex biology. There's also a suggestion they might be protective because the use of ACE inhibitors have an effect on the ACE receptor. So the cardiologists are telling us, don't do it. Don't change. If the patient's on an ACE inhibitor, leave them on it. Taping a surgical mask won't create an N95-like situation. So the surgical mask is incredibly effective at protecting those around you. It doesn't help you. When you if you pull a surgical mask tightly against your face and try to breathe through it, it's very difficult. Actually, it breathes very poorly. And so taping it on might make it very difficult to breathe. When are routine clinics going to resume? Oh, this is like the $64,000 question. I think it's going to be a regional process. In parts of the U.S., we have, again, we promise not to do politics here. We have governors who are trying to open their states up again. But at least in the U.S., we have not been given clearance. In Massachusetts, our governor has us closed at least until the first week of May. I'm guessing it's going to be middle of May, but I don't know. It all depends on what the curve of disease looks like and whether the new cases is coming under control. I think what to use for disinformation, I think they meant disinfection.
Disinfection.
I try not to give disinformation. Disinfection, whatever you would routinely use, we use a bleach-based disinfectant. It's a commercial product. 70% alcohol also works. There's no mystery. This is an envelope virus. It's susceptible to desiccation, ultraviolet light, heat, and alcohol and bleach. So whatever you use in your office for routine disinfection should be okay. I wear eye protection. I have, as you can see, I've reached an age where I need reading glasses. And I fortunately had bought a pair of safety glasses with bifocals in them so that I could work around the house. And that's what I wear. They're wraparounds, and they're crude, but it allows me to see the computer screen. And so I do wear eye protection. And I think even with a slit lamp shield, it makes sense to wear eye protection if you can get it.
Think of cloth masks as well.
So there's an article, and I don't have it all in front of me, but there's an article on the do it at home, do it yourself, the DIY masks that talks about the type of masks, and some are better than others. The cotton doesn't seem to be the best, very helpful at filtering. Denim, interestingly, you can cut up your old blue jeans, seems to be very effective at, and not quite as good as a surgical mask, but quite good.
Okay.
Leaving the mask in a bag for a week is a good idea if you're short on them. And actually, I have a non-medical N95 that I wear to the grocery store. I do the shopping, so I won't let my wife go. I do it once a week. And I leave the grocery store and put it in a plastic bag and leave it on the windowsill. So I've worn it for an hour, and I've worn it 3 times, and seems to be fine. You know, I'm wearing that to protect myself and to protect others. I do think that the virus cannot survive forever outside of a host, and a week should be enough for most surfaces. There's never a guarantee, but I think that's a good practice. Okay, so indirect ophthalmoscopy and how do you protect yourself? I've been asking this of my retinal colleagues, and yesterday I saw an image, actually it might be on the American Academy website now, of someone who had taken a Zeiss face shield and suspended it on the oculars of their indirect ophthalmoscope and created a large shield, and it seemed to be working. I'm sure it was heavy. But you might have to jerry-rig something until they are commercially available. They do make breast shields for slit lamps that you can still buy online, I think, that are very lightweight, and that might work on an indirect. I haven't personally tried it.
So we've included in the resource, remember, for all the attendees, one of the goals is to have tangible ways and sort of a toolkit. And we've included in that toolkit a design by our very own Colin Mann, who's the chair of the CPD. And so he has designed his own ophthalmoscopy breath shield. So you'll get a picture of that as well.
Awesome. That's awesome. Yeah. Antibody testing. This gets back to immunity. In an ideal world, we're all hoping we've already had COVID and that we're positive and that we can just go back to work without infecting our patients or without getting infected again and taking it home. But we don't yet know. And that gets back to the question of whether prior infection protects you. I have a feeling that the answer is not going to be either yes or no, that it's going to be something in between, that probably most people will be infected to some degree from being reinfected, but there will be a subset, I'm sure, based on the particulars of their immune system. There's some data coming out on HLA types that there will be a subset who are susceptible to reinfection.
And along those lines, as a follow-up, what do you think the role of antibody testing for us and our staff as we get back and start gearing? Do you think there's a lot of significance?
So that's a good question. So first of all, in the US, the FDA released companies to make their own serologic tests. And these tests are generated based on FDA guidelines, but they haven't been validated. So there's over 70 serologic tests available now, commercially available, and only 3 or 4 of them have been validated. And so if you're using a non-validated test, think about it. If it's positive and you think you're okay and you don't wear your PPE when you see a patient, well, that would be a disaster, right? So the false positives is a problem. False negatives, not so much, because then you would be protecting yourself. But false positives, and in addition to the false positives, if it's a true positive, but you're not protected because having antibodies is not truly protective against reinfection, then we're no better off. So I think that groups are starting to do research studies on this. They're looking both at the prevalence of seropositivity, but they're also looking at those patients longitudinally to see if they get reinfected. So we'll know that in 6 months, but we don't know it now. I don't know exactly about the distribution of ACE receptors. I thought it was the entire respiratory tract. I'm looking at this question.
So we have time for one more question. Jim, I know you have to skip out as well for other duties.
Yeah.
But we can tackle maybe 1 or 2 more.
in a non-acute care setting. I'm not sure. Well, eye protect. What's the rationale for eye protection in a non-acute care setting? Well, I think in any care setting, the rationale is that if patients with COVID can be asymptomatic or pre-symptomatic, you don't know who has it. The question of why eye protection, there's evidence from other viral infections that aerosolized virus could infect the conjunctiva. There is very soft evidence for ACE2 expression in the conjunctiva. There's one paper and it doesn't really say anything or show any data. It's been repeated in the literature, but the original paper is not convincing. But other respiratory infections like influenza clearly can start with an ocular surface exposure. So the concern is an aerosol with virus gets in your eye and you develop an infection that way. And that gets back to the story of this pulmonologist who believed he got infected. His conjunctiva was the first mucosa surface to show symptoms. And that was pretty convincing to me as to why he would have conjunctivitis before he had respiratory infection. So that's the rationale. So as far as being over 70, I've been asked a lot of these questions. Should I retire now? I was thinking about it, and I think it's a personal decision as to whether you go back to work, retire, or take an extended break. It's very true that risk correlates with age, but young ophthalmologists are dying as well. The ophthalmologist who was the whistleblower in China, who was, I believe, 36 years old, died of COVID, wasn't wearing eye protection in the clinic. And clearly, if you get a coagulopathy, if you get a myocarditis, you can die at any age.
Okay. One last question for you, Jim. As we gear back, everybody's inching to get back into surgery. What do you think the role of ultrasound component of the phaco? Is it considered an aerosol generating? Should we have special concerns about that?
Yeah, that's a really good question. I don't know the answer. I don't know whether that aerosol is going to get out of the eye. Clearly, clearly ultrasound is a concern, but to what degree does aerosol? I don't know if it's ever been studied.
How many times we get splashed, right, with the BSS as we're working?
Right. So it's a potential reason for wearing some sort of eye shield. They make these really cheap plastic eye shields that are very close to the face. That I used one this week actually that did allow me to see through the microscope. The full face shield I could not use an operating microscope, only with the very close eye shield.
Excellent. Well, thank you so much for this excellent presentation and question and answer, Jim. I think your contribution is invaluable because you garner so much different expertise, and I think we're hungry for that at this point. We hear so many different things, and so we really appreciate it on behalf of all of the ophthalmologists in Canada, and I'm sure many international ones as well. I know you have other duties at the hospital at this point. So feel free to tune out. And with this, we'll move on to our next aspect of this design, which is the cross-country. We won't do the poll just yet, but it's the cross-country check. And for that, we've invited Dr. Chris Jackman from Newfoundland, Dr. Ken Roberts from New Brunswick, Dr. Salim Lahoud from Quebec, Dr. Raj Rathi from Ontario, and Dr. Briar Sexton from BC. So yes, Jim.
If I might, I just wanted to thank you and thank everybody who listened in. And I'm happy to speak with any of you if you have pressing questions. And I so appreciate the chance to see those of you who are on. And I have friends among those of you who are logged in. So I'm happy to make some connection, even though it's distant. So thank you so much.
I really think that we're so hungry for all of this that we need someone with the expertise that you bring, Jim, that your contribution has been invaluable in this launching of this series of the webinar. So
thank you.
We are really appreciative of that and hope to see you in person at some point.
Thank you.
Thank you very much. So we'll start with the cross-country check, and we'll start east to west with Dr. Chris Jackman. Hi, Chris.
Thanks very much, Guillermo. Thanks. I thought that was an excellent talk. I really appreciate Dr. Chodish's talk there for sure. We're happy to give my update on Newfoundland. We're still here. We're still as far east as you can get, so all is well.
Excellent. Good. So I know we had sort of sent you some questions ahead of time, and basically we want sort of a quick sort of summary of what's happening in your area, but also
Sure.
something positive that has happened and something maybe not so positive. Maybe start with the not so positive and then finish with something positive that will bring us some hope as to how you're tackling things out there.
So the good news is we're right now we are. I'll start with positive. I'll sort of sandwich it together there. But we are doing well. We've had 7 days now of no cases on the island, so it's been very good. We have less than 50 active cases at this time, so things are coming along very well, which is great. We had started out really strong with a very significant case that basically spread like wildfire through the city of St. John's. In the beginning, and I think we had about 150 sort of associated cases to that particular one patient that came in from out of the province. And so that really sort of scared everyone on the island quite a bit. And but since then, things have really settled down well for us, which is great. So in general, things at this point in time are doing well. We're certainly in a state of emergency, and we've sort of cut down in regards to seeing patients. We're seeing urgent and emergent patients. I'm actually in the middle of a clinic here at the hospital, so sorry for my attire. But things are still going along. We're trying to make sure our patients aren't slipping through the cracks, and still answering our phones at our offices and seeing patients at our offices that require to be seen. But anything that's non-urgent or elective has been put on hold at this time.
Excellent. Thank you. Let me see if there are any other questions. Yes.
Another question was in regards to the optometry. Currently, optometry offices are still closed here on the island, so it is producing some difficulties for people who are looking for vision correction, as is opticals. So trying to get their glasses fixed if they've broken them, that's been a bit of an issue. We've seen a great deal of patients afraid to come in for visits, and that does seem to be improving at this time. We see a lot of patients for injections and things, and they were initially quite scared to be seen in public and coming out of their houses. Luckily now that seems to be changing, and people are a little bit more willing to get their care and their eye care to make sure that they're not going to be losing any vision at this time.
Excellent. Well, thank you. Thank you very much, Chris. I don't see any other specific questions for you, so I'll keep moving west. And
Thanks.
thank you, and stay safe. I know you also have some other duties right now at the hospital. So I'll ask now Dr. Ken Roberts. Well, I'm happy to say sometimes we communicate in Spanish as well. Ken, would you like to go ahead and share what's happening in your neck of the woods?
Thanks, Guillermo. New Brunswick, we're cautiously optimistic as well. We haven't had any cases for six days. We've been on a state of emergency since March 17th. We were one of the first provinces to do the lockdown there. In terms of what I've been seeing with patients, there have been some common concerns, of course, the fear of the unknown, concerned about getting sick or bringing the illness home after coming in for a visit. But with relatively few cases and nearly all the cases now classified as recovered, I'm noticing this week people are more willing to move about while still respecting the state of emergency. Most offices here reduced their volume by more than 90%, only seeing urgent cases and performing intravitreal injections. We send a lot of our tertiary care to Halifax, and the public health officer said that any surgery or service that could be delivered within the province, that's the preferred location. So the positive is we were able to ramp up our delivery of urgent glaucoma surgery with one of the hospitals taking that on, which has been quite a big positive for us. As the disease burden is extremely low, most offices, I think, are planning to open in some capacity in the next 1 to 2 weeks, and hopeful that elective surgeries will resume shortly after that.
So still about 3 to 4 weeks before you think elective surgery will start happening.
Yeah, I'm not sure. We're supposed to get a summary today from the premier of how this is going to roll out, but I'm not even sure who's going to have the guts to make the call to open elective surgery and recall those nurses.
Okay.
Unlike the other three Atlantic provinces, the government has not provided any financial stabilization for fee-for-service doctors.
Okay.
So I'm seeing a lot of concern from my colleagues about paying their rent, paying their staff, paying their leases and their own personal expenses since our volume has been reduced so significantly. We do have virtual consults and virtual visits in New Brunswick, but I think from speaking with colleagues, this has been relatively underwhelming for ophthalmology due to the reliance on physical examination.
Yeah.
All of our optometrists have been closed completely since March 17th. A few of them have taken phone calls from patients, but none are equipped with the appropriate PPE or the clinical background in infectious disease to feel comfortable seeing patients. One positive that did come from this is we were able to create a joint agreement between optometry and ophthalmology about how patients would be triaged and seen, similar to what was done in Manitoba.
Okay.
So I feel like that's been a big positive. Our relationship has been fractured in the past few years, and this is one step to repairing that.
Right.
So.
Excellent. Well, thank you very much, Ken. Thanks for your comments, and we'll keep moving further west. So at this point, we'll go to Quebec with Dr. Salim Lahoud. If you can update us on positives, maybe not so positives, and some other aspects of what's happening in Quebec, Salim.
I would say it's mostly not positive in Quebec because we are the province which has been hit like severely. We have like 21,000 cases of COVID plus patients now, and around 1,200 patients who died from the disease. So the confinement is still on. They are starting to talk about the deconfinement, some of the, some sectors, but it's still very hard. And as you know, ophthalmology has been hit hardly in Quebec. We've been working around 20-25% of our capacity now, so it was very hard. The government asked us to keep the offices open, but it's, patients are not coming because patients are mostly elderly patients and they're afraid of, the disease. And we had to respect the protective measurement we're implementing in our offices. So it's very, very hard to keep them working, but some people are courageous and still working a bit. We're allowed to do emergency cases, urgent cases, and semi-urgent cases. We're planning to increase a little bit the offer in a few weeks, but it's very hard. It's very hard to get it there because the hotspots now are in the CHSLD, which are the centers for elderly patients.
Yeah.
And they're asking even doctors to come help, not like as doctors, but as orderlies and nurses because they're lacking, manpower. And lately they asked the army to help for, offering the services to clean the patient, to clean the floor. It's really hard now. We're not yet seeing the light at the end of the tunnel. So.
Okay. And are you seeing a lot of redeployment of your colleagues as well? Has that started?
Almost 100 ophthalmologists, was available to be redeployed. Some have been deployed, but it's not that much.
Okay.
It's not that much because they want us to stay like a couple of weeks, or it's not 1 or 2 days. So most people have still their office, running. Even though at a lower pace, but they can spend like a week in the CHSLD. So it's hard. We've been solicited, and some work there, and they have stories of complete horrors. Going there, it's inhumane. Patients are left to die probably alone, and they can't see all the parents. It's very hard.
It's tough. And do you anticipate any flattening of all of that, or there's no word on that based on the statistics and the epidemiological?
In fact, what they say is in the general population, it's not so bad. 85% of the deaths are related to the CHSLD, to the elderly people in their centers. So they expect to start deconfinement, and people are going to be allowed to move a little bit, but.
Okay.
It's still dangerous to move around.
Yeah, well, I hope you and your colleagues, your family stay safe, Salim, and we'll touch base with you as we go through the next few weeks. And thank you
Thank
so
you.
much for the update. It's really sobering. I mean, this is serious, and thank you so much for providing a summary of the situation. Thank you.
Thank you.
We'll move on to Ontario with Rash Rathi, please, if you can share your thoughts there, Rash.
For sure. Thanks a lot, Guillermo, for the opportunity to speak about. I think the whole country is in the same situation. We're all we're all socially distancing. It's a new norm. In Ontario, there may be the next step, maybe actually wearing masks in public and being required to go even to grocery stores, as I've heard, even as recently as today. So things are changing, and it looks like these measures have been making an impact. The big surge that was expected, a lot of us ophthalmologists were actually deployed to help out in the internal medicine wards. And luckily, that surge hasn't really happened. There are a lot of sick patients. There are a lot of deaths. We're very aware of that. But the system has not been overwhelmed the way we expected to. So that's a lot of good news. Unfortunately, elective care is completely on hold, like everywhere else. And patients are fearful to come in, as you've heard from the rest of Canada. No different here. And we're similar in Ontario. Most offices are operating with a skeleton staff, minimum inpatient visits. There is some virtual care, which is challenging for us as ophthalmologists. And we do have some phone and video codes from the Ministry of Health, which really is just a drop in the bucket. Most offices are seeing minimal patients.
Okay. So I hope, before I move on, Raj, I just want to comment that what we're getting is a full perspective, across Canada perspective from people who are involved with the executives of the provincial associations. So we're really getting very, very important data from Newfoundland, from New Brunswick, from Quebec, now from Ontario. When do you expect to see things change?
Well, our Premier, Doug Ford, has actually been praised for the way he's handling things, and he's expecting a lockdown probably till about the May long weekend, towards the third week of May. A couple of things that are kind of interesting is that we have seen success. So you asked about the good news. Well, there's the good news. It looks like the measures being taken are working. And the other thing it's interesting, the side effect in Ontario, we've got a very big bureaucracy here. I think it's actually brought doctors together. It's not just ophthalmologists, but all physicians are really struggling because it's not just about patient care. It's also about our offices, our income, our ability to sustain our healthcare system once this is over. It's not just about COVID. We're all very concerned about this, but we want to have a functioning system to take care of patients in need, whether it's the cardiac patient, the cancer patient, and certainly vision loss is an extremely serious issue for patients. Patients fear losing their sight terribly. So we need to have an infrastructure in place once this is done. And the government here has been a bit tricky and a bit sneaky. They've been negotiating with the Ontario Medical Association, and they've offered a 75% advance to our billings that we normally bill. So the newspaper publishes this and the public thinks we're getting paid, but it's an advance. Basically, it's a loan to be recovered by next spring. So we're fighting this, and that's brought a lot of doctors together to contact their MPPs, to contact the Premier's office directly, and to really try and work together to make the politicians and the public understand how important it is for us, because there's going to be a huge surge post-COVID in the need for services, especially elective services, whether it's a hip, cataract. I think these are things people need, and they're all being put off. So a little bit of optimism that we're really working together to try and get something, because right now the government's been a bit disappointing from our perspective as doctors.
So yeah, if we can keep track of that, we're in this together after all. So thank you very much, Raj, for your perspective. And we'll move on to Dr. Briar Sexton, representing Biceps in British Columbia. Briar, great to see you.
Great to see you too, and thank you again for organizing this. It's been great. Not too much to add to what's been said already. We've been essentially shut down other than emergency services since around March 17th. There haven't been elective surgeries going on. What I'm hearing from my colleagues is that most people are seeing only absolute emergencies, intravitreal injections. A couple positives. Dr. Heather O'Donnell set up in our province a COVID-19 WhatsApp group. And that's been a really great way for us to communicate with one another. And I'd encourage any province that doesn't have that to start it. We've been able to help discuss issues like PPE and what types of patients we're seeing, different virtual health platforms. And that's been definitely something that has been great for us here in BC.
Mm-hmm. How do you see the relationship, the support with optometry? Has that worked a little bit better during this crisis, or what's the situation there?
It's been great. Bill Johnson and Ron Baldessare, who are our BCEP's presidents, reached out to John Lamb, who's the president of BC Doctors of Optometry, and talked about PPE, talked about appropriate care. And John sent out from BCDO basically asking all of the offices to close, but also communicating that we'd like them to keep a phone line open, both so that they can direct patients to us as needed, but also lots of times we've had patients come in that have had a recent optometric exam we don't have access to. And when we're trying to provide virtual care, being able to get that information has been really helpful. I did a webinar for the BC Doctors of Optometry on COVID-19 that had, I think, 270 participants. So definitely they're hungry for information, and it was great that they're looking to ophthalmology as a credible source. And I'm doing an update with them in a couple of weeks, so that's been a real positive as well.
Excellent. I think, you know, one of the aspects that we've been discussing is how can we take advantage of this crisis to develop platforms that will allow us to work better, collaborate better, and perform better our duties as surgeons or practitioners, and also as collaborators after the crisis is over. So it sounds like within all this turmoil, there's some glimpses of positivity throughout the country. So thank you so much, Briar, and to all the panelists, including Chris Jackman, Ken Roberts, Salim Lahoud, Raj Rathi, and Briar Sexton, representing their provincial organizations. They really know what's happening there on the ground. I really thank you all, and I hope you all stay safe. And we'll move on with this to the last part of the webinar, and I'll share my screen again. So we have another poll to finalize, and this is sort of, it deals with the returning to normal. And I'll ask Colleen to share that. So what do we expect after this session? We've been talking about a lot of different things about masks and gloves and all of that. So once you return to a new normal, seeing elective consultations in your office and seeing what's happening across the country, what is the closest to the PPE you will be using? So none, breath shields on examining equipment, hand washing or gloves, mask, eye protection, and you have the options there, all the way to full PPE, mask, gloves, gown, eye protection, and breath shields on examining equipment. And so if we can see the results, Colleen, there we go. So hand washing or gloves, mask, eye protection, breath shields on examining equipment. I'll ask some of our panelists from across the country, like Briar, Raj, Salim. I'm not sure if Ken and Chris are still on, but any comments on that? What do you think? Is this realistic, Raj, for example?
Yeah, I think it is. I think it's very realistic, and I think that's what most of us are doing. Just being reasonable, being careful.
Excellent. Any other comments, Briar, that you would see are important?
Nothing specific. I mean, I think that we're going to continue to see people being more careful going forward, and certainly it's heightened all of our awareness. I didn't have a breath shield on my slit lamp.
Mm-hmm. How about you, Salim? How do you see the setting of the hotspot in Canada?
Yeah, it's almost the same. I will add the mask for the patient.
Mm-hmm. Mm-hmm. Excellent. Yeah, we've been doing that. As a matter of fact, we give them cotton masks and we clean them right in the office. We wash them on the sanitizing mode as well. So we sort of keep using them as an extra additive protection. So with this, we'll move on to the last part of which is basically how do we get credit for this? We get credits for continuing professional development. And the first thing I would do is encourage you to visit the Practice Resource Center. And here's the link for that. And then I'll also ask Colleen to pop on the next few questions. These questions are important. Don't log out yet. these questions are important because these are the ones that sort of complete the assessment and complete the section 1 credits, which are also important to have in this point. So, Colleen, I wonder if you can provide those questions now.
Absolutely, Dr. Rocha. We
Questions.
also had some assessment questions, if you'd like me to share those before the evaluation questions.
Let's do that. So we really want to know if you think this webinar should be held on a weekly basis, bi-weekly, monthly, and also based on your experience with today's webinar, if you are definitely planning on to attend the next one in the series, likely to attend the next one, not likely. I hope it's not the last one. And we can pop the answers there, Colleen.
Absolutely, sharing results right now.
All right. So most people want to attend, and we either do it weekly or bi-weekly. And this is great to hear. And then we'll pop the assessment questions. You need these. Don't log out yet. You need these to get your credits as well. It's good to get some kind of credits right now that we're not working. So you have 6 questions there, just yes, no. And I'm not sure, Colleen, do we show the results for this, or this is just for each of the attendees?
I believe that's just for us, so I will close this poll once we have some results.
Okay, excellent. So I'd like to, before we wrap up, I wonder if there are any other questions, any burning questions. Colin and Hadi, you guys have been monitoring the questions. Do you want to pitch in any comments that you would like to make, or any other comments also from the members of the CPD Council as well before we wrap up?
Sure. Thanks, Guillermo. Just on behalf of the CPD Council, I want to thank everyone who took part in this. The members of the council were the planning committee, and Guillermo, I want to thank you for stepping up and leading us through this. It's been a wonderful session. A couple of quick comments. One would be, we'll look at the questions that we didn't get to, and if there's ways of addressing those in future, we will do so. I also would direct people to the PRC, the Practice Resource Center. The link is on there, www.cosprc.ca. There will be a document there which will be a legacy from this webinar with some links, some interesting articles that Guillermo has put together, some links to things like how to make your own indirect ophthalmoscope shield. I know Dr. Baez has been instrumental in getting breast shields made available, and I know most of them are already spoken for, but there's probably still a few, and so that'll help us as we get back to practice. So there will be some some toolkit sort of takeaways from this. Go to the PRC, and those will be up in the next day or so for you. And I know Guillermo is going to tell us a little bit more about how this series is going to continue.
Excellent. Yeah, I see Mona there activating her video. Mona, do you want to have any comments? You're the chair of the annual meeting, and any comments from you? Alan, you're on mute, sorry. There you go.
I just wanted to congratulate the team. I saw that the attendance was over 400 and some, and Colin, thank you for this great initiative. Thank you, Yvonne, for your leadership again. And wonderful work, Guillermo.
Thank you. And Hadi, any last comments from you?
Mostly to say thank you and to let everyone know that the next session is planned for next Thursday. You will get an email with details about that. Oh, there you go. Well, I'll let you take the lead then. Thank you. Yeah, so we're planning to do this. We had to adapt. We really wanted to start with somebody like Dr. Shodash. So we adapted it to the Friday. But I would like to note that the subsequent sessions will be on Thursdays at 4 p.m. Eastern Time. And the next one we're planning on will be on medical legal aspects of ophthalmology practice during the COVID-19 pandemic. With that, I would like to thank a few people. First of all, the CPD Council for, I thought I was ready for retirement from the COS, but they dragged me back, and it's been an honor to
to help prepare and moderate these sessions. I'd like to thank the presenters, Jim Shodosh, to all the panelists as well from east to west, all of you, the participants. I remind you that this is a session that gives you CPD credit, so that's very important as well. We will have on the PRC, the Practice Resource Center, a login with the resources, the toolkits, some of the things that Colin mentioned, as well as eventually we'll have a recording of this session as well. And finally, I'd like to thank our sponsor for the unrestricted grant by Bayer, and we hope to have these sessions every Thursday at 4 p.m. as well. I think we talk a lot about physical distancing, but certainly there's no social or scientific distancing. I think these sessions are making us stronger as a community and stronger as individuals, and I hope all of you stay safe and stay well, and I hope to see you here next week on Thursday.